Hello and welcome to the EMS Focus Webinar series hosted by the National Highway Traffic Safety Administration's Office of Emergency Medical Services. My name is Clary and I'll be moderating today's session. This webinar series is designed to provide useful information to EMS stakeholders about federal, state, and local participation in planning, designing, and advancing EMS. Today's webinar is being recorded and will be posted on ems.gov. For more information about EMS Focus webinars, to access archived recordings, or to learn more about the Office of EMS, please visit ems.gov. Feedback and questions about the webinar can be sent to nitsa.ems@dot.gov. Later in our presentation, we'll hear from Dr. Levy on the Prehospital Blood Transfusion Clinical Practice Guidelines, which were developed by the Prehospital Blood Transfusion Coalition. As the lead author of the guidelines, Dr. Levy will share key insights into their development and discuss how and why EMS agencies can begin incorporating them into practice. Before we begin, let me go over a couple items with you. You can use the Zoom control panel Q&A button to submit questions throughout the webinar, and we'll address those during the last 15 minutes of the webinar today. Our facilitator will organize questions for the Q&A portion. Closed captioning is also available. To enable this feature, simply click Closed Captions or Show Captions. Let's start by taking a few moments to focus on the mission of the NHTSA's Office of EMS. We support the nationwide improvement of patient care in the out-of-hospital setting by doing the following: bringing together data and experts to identify critical issues in the EMS field, collaborating with partners, including other federal agencies and national organizations to address those issues, and promoting awareness and education about best practices and evidence-based guidelines. One way we achieve our mission is by providing resources to support EMS leaders and clinicians. The Resource Hub on ems.gov makes it easy to browse, search, and download documents, reports, and guidelines. These resources were created by the NHTSA's Office of EMS, FAEMS members, and others to help advance EMS practice. To access these materials, scan the QR code on the slide or visit our homepage at ems.gov. It's a priority of NHTSA's Office of EMS to address preventable causes of death in the out-of-hospital setting. One of the most significant and urgent challenges we face is severe bleeding after traumatic injury. This is why today we are focused on pre-hospital blood transfusion, an intervention that can have significant impact on an agency's ability to save the severely injured. As you know, NHTSA is a public health entity that focuses on the issue of death and serious injury on our nation's roadways. Tens of thousands of people die in crashes annually. NHTSA data show that 43% of those victims were still alive when EMS arrived on scene. The problem is too many of these patients aren't surviving long enough to reach the hospital. Pre-hospital blood transfusion will help fill this gap, giving patients a better chance at survival and clinicians the time needed to transport them to preventative care. The challenge is not just delivering care, but delivering it as a part of a seamless system. Survival improves when 911, bystander response, EMS, and hospitals are all performing at optimal levels. Pre-hospital blood transfusion strengthens the chain and buys more time for patients to reach the hospital. Severe bleeding can cause death in as little as 5 minutes. IV fluids cannot replace lost blood cells. Pre-hospital blood transfusion gives EMS the ability to address the problem immediately and keep patients alive through the critical moments between onset of illness and injury and arrival to the hospital. Research shows that pre-hospital blood transfusion could save up to 37% of trauma victims, trauma patients with severe bleeding. This represents thousands of lives that could be preserved each year. This is why agencies across the nation are establishing and implementing pre-hospital blood transfusion programs. The first step to implementing a pre-hospital blood transfusion program is building strong partnerships with hospitals and blood banks to ensure access to a blood supply. The development of protocols and training for EMS clinicians is critical to ensure blood is safely and appropriately administered. Programs need to plan for logistics such as storage, transport, and strategies for minimizing waste. Many agencies start small, then expand as they gain experience and demonstrate success. The previous slides that were created from new infographics that are now available on ems.gov. They are designed to be simple, visual, and easy to share with stakeholders who play an important role in establishing a program in your jurisdiction. Those can be used to facilitate conversations with elected or appointed officials, the public, highway safety leaders, and even your colleagues in 911. Access those materials on ems.gov or simply scan the QR code on the slide. It is now my pleasure to introduce Dr. Levy. He is the lead author of the Prehospital Blood Transfusion Coalition Guidelines. Dr. Levy, please walk us through the guidelines, share lessons learned, and explain what EMS agencies should know about implementing a prehospital blood transfusion program.
Absolutely. Claire, can you hear me okay?
I can.
All right. Well, thank you so much for the introduction and for the amazing work you and the NHTSA team have been doing and continue to do on behalf of EMS in the country and on behalf of advancing our goal towards zero preventable deaths from trauma and injury. And it's a privilege to speak with you all today. As Claire mentioned, my name is Matt Levy. I am an associate professor of emergency medicine and surgery at Johns Hopkins, chief medical officer and EMS medical director for Howard County Fire and Rescue, and have had the incredible privilege to be the lead author on the Prehospital Transfusion Coalition Civilian Practice Clinical Practice Guidelines. So we're going to go through them. So just a few things, a couple of disclosures and comments up there. From a disclosure perspective, any opinions expressed here today are those of my own and don't represent any agency or employer that I may work for. Before I jump into the guidelines, I really need to just pay homage to and shout out to my amazing team, or our amazing team of co-authors and leaders that are absolutely deserve as much credit for this as anyone else does as it comes to the goal of advancing access and implementation of pre-hospital blood programs across the country. I would recommend and would just call out that they are, many of them are in the audience and we're able to connect today, but many are traveling. So we just acknowledge the amazing work of this team, Dr. Randy Schaefer, Lieutenant Holly O'Byrne, Dr. John Kramer, who needs no introduction amongst this group as for all he's done, Chief Eric Bank and Dr. John Holcomb. Just been the privilege of a lifetime to collaborate with these individuals. What we're going to do today in the next few moments is we're going to talk a little bit about the role, the purpose, and the components for the Prehospital Transfusion Coalition's clinical practice guidelines. We're going to speak about them from the perspective of what you can, how these were designed and intended, and how you can use them to help advance prehospital care in your communities. So first and foremost, we really need to talk about the disease state that is trauma, hemorrhage, and death. For all the wonderful advances in technology and for all the amazing systems of care that we are all part of and we have all built, we have to acknowledge the fact that we still have a survival problem. Clary, you mentioned this a little while ago in terms of some of the challenges we face with roadway trauma. But trauma remains the leading cause of death for those under the age of 44 in the U.S. and is a leading cause of death in all age groups, I should say. And even more concerning is that nearly or upwards of 74% of our prehospital trauma deaths or trauma deaths occur either in this prehospital phase of care or during that first hour. And we know that hemorrhage, the first hour after hospital arrival, we know that hemorrhage accounts for upwards of 40% of these deaths and is the leading cause of preventable deaths. So we really have identified an opportunity and a problem. Many of you on this call have been involved with the Stop the Bleed initiative, and we know Stop the Bleed has helped save many lives. We also know that we now need to fill the tank, if you will, after the bleeding is stopped. And that's really where prehospital transfusion comes in. If we were to contextualize the challenges that we have and think this through from the perspective of how we built our systems of care, I would summarize it by saying this, which is the problem is, very simply put, that you think you have time. The problem is that we built systems to get patients to hospitals and definitive care within the golden hour, but we have to acknowledge the fact that many a patient will succumb to their injury or their life-threatening hemorrhagic shock from a medical before that golden hour time passes. And we know that there is an inflection point and around that 30 to 34 minute point in time, and the reference is up there for you. And it's with this concept in mind that pre-hospital blood administration really has evolved into a first and foremost, kind of approach towards solving and saving more lives. But as I alluded to a moment ago, I would offer that it's not just our trauma patients, because we know that medical patients experience hemorrhagic shock for any number of reasons, from GI bleeding to peripartum hemorrhage to epistaxis to dialysis grafts that bleed, through a variety of other conditions, that some of which I've listed up here. So we know that yes, there's a focus on injury, and yes, there's an opportunity for us to really save lives in the acute phase of care following a crash or following injury and trauma. We also know there's a medical opportunity to improve outcomes as well. So it's on the heels of all that let's talk for just a minute before we get into the guidelines, but how we got to this point. Because I think it's important to understand and to acknowledge that giving blood to patients who are dying is not a new concept. Okay. In fact, it is rooted in military medicine and was done in mass back in World War I and even into World War II and even into Vietnam. It was curtailed due to some infection control concerns and disease transmission. And in the 1970s, there was some push towards crystalloid use, which has become or had become the mainstay of pre-hospital trauma resuscitation fluids from the perspective of giving volume expansion. But we now know some of the many challenges that crystalloid can cause. Over the past 2 decades, we've seen a growth and an expansion of pre-hospital transfusion into the civilian EMS sector, principally starting with air medical assets, our rotor wing, medevac helicopters, fixed wing as well. And then very interestingly, within the past decade, starting around 2015, 2016, we began to see the use of blood products in certain forward-leaning, cutting-edge EMS systems around the country. And it really got some thought leaders scratching their heads saying, there's really something to this. Early on, the blood programs really focused on transfusion of red blood cells, packed red blood cells, or RBCs, or packed cells, if you will. And that was primarily due to what was available. That's what was available at that time. But over the past, I would say 7 to 8 years, we have seen a shift towards the use of low titer O positive whole blood and also plasma. We'll talk about plasma later. And the idea here is to give these patients back what they're losing, what they're bleeding, and that's going to be the focus here of what we're going to talk about. And what we're really getting to, everybody, is this concept of balanced blood transfusions. Because when you bleed, and when you're bleeding and going into hemorrhagic shock, you're not losing just red blood cells or just plasma or just platelets. And whole blood represents the closest thing that you can get to normal blood composition. I say that closest to because it's still not. There's some elements, including how we have to preserve the blood and stuff like that. But historically, whole blood was not always available. And it was because of that lack of availability, because of, for reasons that are beyond the scope of this talk, but have to do with the fact that we can help a lot more people with one unit by separating it out to these components, except those people in acute hemorrhagic shock. So the idea here was getting back to giving someone as close to what they're bleeding as possible. And when we think about that, in comes the concept of low titer whole blood, and many places are using low titer O positive whole blood because of availability. But I want to just take this moment just to kind of level set and lay the stage for what we're going to talk about with these guidelines as to how we got here. So when we think about low titer O positive whole blood in particular, we know that it is the complete product that contains low levels of antibodies, making people less likely to have a reaction to it. It is type O positive because type O is universal donor, and the majority of the population is Rh positive. We'll talk a little bit, because the guidelines, we do get into this about alloimmunization and some risk for female childbearing potential. But it's the whole product. It's whole blood. It contains all the components, RBCs, plasma platelets. And it is licensed by the FDA and approved by the American Association of Blood and Biotherapies, who are an amazing partner on this journey, for emergency release for life-threatening situations where blood is needed and we don't have the ability to type and screen and give the patient their own blood type. And it has emerged as being the first choice for resuscitation in massive hemorrhage for more than half of their trauma centers, or level 1 trauma centers in the US, and an increasing number of pre-hospital EMS systems, which is why we're all here. So it's with this kind of context that the evidence really has gotten us thinking about how can we improve outcomes. And there are a number of data sets that suggest, a number of papers, some of them are listed here, that do show suggestion towards improved outcomes for trauma patients. And many of these papers occurred either in the trauma bay, some are military, but the concept is doing this faster and sooner, with the idea of getting that blood into that person within less than 35 minutes of injury can improve their survivability. So on the heels of all that we just discussed, we now have we have EMS systems that are out there innovating, that are out there trying to save more lives in their community, and had been working asynchronously within their communities to really implement pre-hospital transfusion programs, and have done an amazing job of that. In fact, as of today, there's more than 280 ground-based EMS systems around the country that are administering pre-hospital blood products. The majority being low titer O positive, but some are using platelets and some are using packed red blood cells based upon availability and resources. The Prehospital Blood Transfusion Coalition, which I'm honored to be a part of, is a group of like-minded people. It's a whole group that includes EMS system leadership, medical directors, industry leaders, the blood community, the blood supplier community, the professional organizations, and it's led by an amazing board of directors. And I would point you to the coalition's website, prehospitaltransfusion.org, as we all wrap our heads around this challenge and opportunity to save more lives and decrease death from hemorrhagic shock. And I've listed some of the coalition's mission and some of its efforts that are underway to try to improve outcomes. And one of the things that the coalition has done, and I would encourage you again to check out the website, is the coalition has really shared some amazing data about where programs are and what types of programs are. And there's an interactive map that you can view on the coalition website. And there's also an update map that shows which EMS states are allowing blood transfusion in the field by pre-hospital clinicians. And the work of the executive board of the coalition, led by Dr. Kramer, has really been remarkable and continues to really make important headway. And one of the things that the coalition tries to do and really strives to do is to be a resource for those organizations looking to start or implement pre-hospital blood programs, but also for those who have already implemented pre-hospital programs. And it was on the heels of that notion that we began talking a few months back about the importance of providing a reliable, easy to use, easy to access set of clinical practice guidelines to help guide those EMS systems looking to plan programs, or for those who already have programs looking to actually just kind of do a spot check, or to maybe optimize, or to get a sense as to what the current evidence and data are. And the QR code that is there should take you to the link to the guidelines. They are open access, they are free to download, and they're meant to be a tool for you and for your teams on your journey towards improving outcomes in your communities. So you may be asking yourself, well, there's a lot of data out there, there's a lot of resources. Why do we need these guidelines? Well, the intent and the purpose really is multifactorial. But above all, as evidence increases supporting pre-hospital transfusion, and as more and more folks and more EMS systems start implementing pre-hospital programs, we wanted there to be some strategic alignment or some ability for people to have a boundary or a reference set of materials they can use to help guide their implementation. That was a consensus-based, driven by the best evidence and data that we have. And as these programs grow, there's more need. The details, though, matter, and I have to emphasize this to everybody. The details surrounding these programs really matter. How we do this matters, how we implement this matters, and perhaps most important of all, being good partners in a very complex and often fragmented health system and trauma care system matters as well. And so for that reason, putting together these guidelines became a passion of the team. The guidelines themselves are rooted in current evidence and best practices and really provide a roadmap for people to follow. And we'll get into this a little bit more about what the guidelines are and what they aren't. Many EMS systems early on found themselves trying to translate and adapt military guidelines or military practice to the civilian world. And we know that that's not always directly translatable. And we know that there's opportunity there for translation errors. So we wanted to help navigate that process. The last thing I want to point out about the guidelines is that they're a living document. They're going to evolve. They're going to change as the evidence changes, because that, as a scientist, as an academic, as a clinician, that's what we do. As we have more data, as we have more evidence, we increase recommendations. So these guidelines are current and will be evaluated periodically moving forward, and updates will be released as appropriate. So I've mentioned some of this already. These guidelines represent that of the Pre-Hospital Blood Coalition. They've been approved by the board. They are in alignment with professional society position statements, so there's no conflicts there. And they're meant to be a resource, a roadmap, if you will. What they're not meant to be are a set of regulatory guidance, right? These are not regulations. These are not laws. These are not the only way of doing it, but this is meant to be the guidelines to help you on your journey. Very important along those lines is they don't supersede local protocols or local medical direction. There might need to be some variability, or there might need to be some tolerances that are changed at the local level due to any number of reasons. And they're meant to be implemented in concert with local medical direction and oversight. But above all, they really serve to help ensure safety, accountability, efficiency, training and policy, and appropriate clinical practice. So that's really like the big picture stuff. And as we think about this, that was the job we set out to accomplish in writing these guidelines. And the guidelines have several different sections. They start with a preamble and a purpose. We felt it very important. We'll get into each of these to talk about the principles of resuscitation, criteria for transfusion, the procedure of transfusion itself, documentation, quality and safety, training and implementation. So the guidelines, this is the kind of the big picture table of contents, if you will, of the guidelines, but this is the sections that we have for them. And getting right into it, I would say that it's worthy of taking a moment that early in the guidelines, we felt it important to call out what may be obvious to some, but to others, it's absolutely key that this is about being on your A game. And even if you are not yet at the point of implementing a pre-hospital transfusion program, being on your A game for trauma care and for a resuscitation of critically ill and injured patients starts right now and needs to. Right? It's effective communication. It's managing multiple urgent interventions in parallel. It's structured handoffs of care, ensuring that key information isn't lost. It's continuity and consistency from the type of care we're giving from the field all the way through to the hospital. And it's standardization of procedures and practices. Whether you're at the point in your EMS system's evolution of doing blood or not, in order to use blood effectively as part of your resuscitation arsenal, you got to have all this stuff in place. And that would be one of the most important messages that I would want to share with everyone today. Now, as we get into this a little bit more, we know that we roll up our sleeves and we get to work on these patients. We know that it's very important that we rapidly recognize hemorrhagic shock, that we understand and have access to effective hemorrhage control abilities, products, interventions, technologies, and that we have a strategy for hemostatic resuscitation or for resuscitation with blood products. And the coalition guidelines call out that if possible and available, low titer positive or whole blood, I should say, should be given. Or if you don't have that, plasma or packed red blood cells. If you're going with packed red blood cells and because that's what's available and that's what your region can have, that's fine. Just know that we need to be mindful that we want to try to maintain a 1-to-1-to-1 ratio of packed red blood cells to plasma to platelets to ensure we're getting as close to whole blood as possible. So there may be some catch up at the hospital. I think we all probably know at this point that the importance of minimizing crystalloid use is absolutely paramount. There is a small role for crystalloid, but that's only after we've exhausted the other blood products. Prevention of hypothermia, the use of pharmacologic adjuncts, including TXA and calcium, also very important. Now, one of the things that we really set forth to do was to help help lay the foundation for who should and shouldn't be getting blood pre-hospitally. Because, ladies and gentlemen, you have to acknowledge that this is an emergency intervention. This is a resuscitation intervention. And we want to be very clear that we preserve this very precious commodity that is blood and blood products for those who need it the most, those who are going to benefit from the most. And that's where this risk-benefit calculus of giving on-cross-match products to patients errs on the side of benefit, not risk. So we have to think about these patients who are in hemorrhagic shock, right? Hemorrhagic shock with hemodynamic instability, traumatic injury, significant blood loss, signs of shock despite initial resuscitation. There may be clinical judgment that is incorporated, which we'll get to in a second. And we have to think about the nature of illness and mechanism of injury. The excerpts from the guidelines are right on your screen here for you, which you can read later in details. But what I would say is we really want to have a well-painted picture that this person's in a shock state. And we want to use not one, not two, but multiple streams of data to help us arrive at that conclusion. And that becomes really important to make sure that we stay on the right side of right with this. We included several examples of patient presentations with suspected hemorrhagic shock that would maybe necessitate blood transfusion to have it more on the front line or the foreground of your mind as you're on these scenes. And some of these are pretty common sense things: amputations, requiring tourniquets, severe thoracoabdominal trauma with evidence of shock, evidence of significant blood loss, as we define it as greater than 550 cc's or mLs, unstable pelvic fractures. And just a word about these pelvic fractures, boy, do they bleed a lot, and you won't see it externally. It's amazing how much blood can be sequestered in the pelvis. And I know we all know that from the tests we've taken over the years, but have a healthy respect for them. And then the medical things, which you've already talked about. In the interest of time, I'm going to keep going here. So as we think about what the guidelines, what we put into place here, these may look similar, but not exactly what you're doing in your neck of the woods if you're giving pre-hospital blood in your EMS system. But thematically, they should be very much the same. Pre-hospital blood products should be used for those patients in hemorrhagic shock. And we've taken and we've made an effort to dispel or to unpack how we define hemorrhagic shock. And I would point out a few things here. Just we do mention the shock index. Some systems are using shock index. That's great if you are. But shock index, I don't know about you guys, but when I was a medic in the back of the unit, 3 a.m. doing med math was not going to be my strong point. So we have to be mindful about how and when we apply the use of calculations and stuff like that. So maybe it's a systolic blood pressure cutoff or a heart rate cutoff. And for pediatrics as well, knowing pediatric heart rate and blood pressure cutoffs. And then, of course, equally as important in my book are the physical exam findings that indicate this person's in a shock state. Everything from altered mental status to capillary refill that's delayed. That perfusion exam, we talk about checking cap refill, we talk about an EMT school, but then when we get to like it somehow gets lost in the sauce as we're doing our assessments and our treatment. But now as an attending physician working in a level 1 trauma center, let me tell you, that perfusion exam really means something to me. Are they perfusing their tissue? Yes or no? And end-tidal CO2, stay tuned for more about that, but I would tell you that end-tidal CO2 is also another great marker for acidosis in the body and for a shock state. So we also wanted to make sure that in the guidelines, we spoke to some of the very special circumstances that we see pre-hospitally. Bleeding disorders. What do we do for patients with bleeding disorders? Hemophiliacs and other types of bleeding disorders. Well, if they're in shock, they should get the blood products, but we may also have to make sure that we get them their appropriate countermeasure, factor, or if they're coagulopathic and due to medication, giving them the appropriate reversal. Pediatric dosing, this was the agreed upon and consensus base for how we would probably think about dosing blood products in the pediatric environment, with that line in the sand being around 35 kilos. If the child is less than 35 kilos, we use a 10 ml per kilo calculation. Once they get above 35 kilograms, we think about 1 unit of blood product. And again, I would mention that not just for pediatrics, but for adult patients, our resuscitation targets, if there is evidence of traumatic brain injury, should be a systolic of at least 110 to perfuse the brain. Now, let's talk for just a minute about something that sometimes causes systems a lot of stress and a lot of angst, particularly for our hospital partners, and rightfully so, which is the risk of anti-D alloimmunization in females. Now, what does that mean? Well, very simply put, we know that we're using most EMS systems, and there are some that are using negative, O negative blood product, but most are using an O positive product. Why? Because of availability. And because with low titer O positive blood, the risk of antibodies and of isoimmunization tends to be lower, or alloimmunization tends to be lower. And so we have some math there. What I want you to know is that that the consequence of giving a female of childbearing potential who's Rh negative an Rh positive product is real. It's lower than maybe we initially thought, but it's real. And most importantly, in order to stay on the right side of right here, we have to be very true to the fact that if we're doing this as a resuscitation intervention, we're giving this blood to save their life because they met those shock state conditions that we just talked about, then the risk of death from hemorrhage is much greater than the risk of this alloimmunization or having mom develop. So the concern would be if that Rh negative mom were to get pregnant and have an Rh positive fetus, her body could reject it, and there could be other issues that can result. We call this female hemolytic diseases of the fetus and newborn. And just to illustrate this for a second, I wanted to show you, this is what we're talking about. And my colleague, Dr. Mark Yazer, I don't know if Mark's on the call, but he and his team put together this wonderful infographic, which really shows all the things that have to line up to happen for that risk to affect the unborn fetus, including the fact that the person has to survive their injury and get pregnant and all these other things. So I say that to you all, not to be dismissive. In fact, the opposite, to understand that this is why we need to be really thoughtful about who we're giving blood products to, on cross-match blood products to, and who we're not, because there is risk. Not zero, but there is risk. So if we stay on the right side of right, we should be okay with helping do more good than harm, but this will happen, and there's a whole other discussion to be had about how we manage that risk. What I want to do here is pivot for a second, though. I've talked a lot about the theory. I've talked about indications. I've talked about definitions that we should be using and things like that. And what I would say is in the formatter of the guidelines, folks, we talked about the fact that these guidelines are used to inform local protocols. And so translating these guidelines into local protocols, one of the things I would tell you, if you're joining the call and you're feeling a little overwhelmed and maybe your system is moving towards pre-hospital blood but hasn't gotten there yet, don't reinvent the wheel. There's 280 of us around the country who've done this, that we've implemented programs, and we've learned from each other along the way. Along those lines, what we would say is, here I included a copy of our Maryland protocols that we use for blood. Maryland's a little bit different in that we have statewide protocols and statewide oversight of our systems. But what I would want to implore upon you is that there will need to be some local translation to how you're going to do business. So what you want to do is have alignment with the protocols. It may not have your protocols aligned with the guidelines. It may not be a one-for-one, but just to give you an example as to how the guidelines can then be used to inform protocols. Now, let's pivot for just a few moments, everybody. Let's talk about some of the other stuff that we put in the guidelines, right? Let's talk about equipment and blood storage, because this is on everybody's mind. And I have to tell you, this is now my 31st year in EMS. I started off as an EMT, then became a paramedic and went to med school, and here we all are. And what I will tell you is that we do logistics better than almost anybody else in healthcare. And we should be proud of that in EMS. One of the things we do really well is logistics. And so we are up for the challenge of maintaining a cold storage system for blood products. Because you have to, it's very important, right? Blood is this precious commodity. We can't let a unit go bad because it fell out of storage chain stuff, right? So that there's a narrow threshold of tolerances for how we have to store blood, between 1 to 6 degrees Celsius, okay, for storage, or 1 to 10 for transport. And we need to have alarming and monitoring capabilities. There needs to be crystal clear documentation and accountability. And that container, the system that you're using, has to be validated by your blood supplier and by your local stakeholder groups. And it's very important that we have our ducks in a row here. And then we have to have the requisite equipment to give the blood to the patient, including warmers, if you're using warmers in your system, infusion devices, blood administration tubing sets, and the appropriate vascular access and monitoring. So as I mentioned a moment ago, maintaining a cold chain is very important, right? This cold storage chain is very important. This requires coordination with blood suppliers. We have to be absolutely steadfast with adherence to temperature requirements and temperature monitoring. we really want to strive to have protocols that allow us to rotate. Now, I don't mean treatment protocols like we operate under an EMS. I mean procedures and policies with our blood supplier community. When I say protocol here, that we can rotate the unused blood back into the systems so that we can minimize waste. And of course, the transport procedures for the blood product have to be built out. And ideally, what we want to do is build a zero waste system where that blood is rotated. Think of it more like a blood library than a blood bank. You check it out on day 1, you check it back in on day 14 so someone else can use it. That's what you want to try to do. That's not always possible, but building that cold storage chain and having accountability for it is a first step in that right direction. There are no brand endorsements on this talk, but I did want to show some pictures as to some of the storage devices that are out there that you may encounter, because I want to demystify some of this. And I want you to know that we've figured this out. And these 280 programs that are out there doing this right now, that are members of the coalition and that are doing this amazing work and saving lives, have figured out how to do this. So don't reinvent that wheel. Now, let's get into the nuts and bolts of giving the blood, of actually giving the actual procedure. So we talked a little bit about the indications. We talked a little bit about the preparation and storage. And one of the things that we put in the actual clinical practice guidelines was this checklist that you can kind of use as a big picture nuts and bolts checklist to inform the development of your own personal EMS systems checklists, right? So first things first, does the patient meet criteria? Secondly, we are assessing for the indicators for the blood, and we're going to get access. We're going to talk about all of the pieces here. We're talking about verification of the blood products. We're going to talk about checking that blood is in range. We're going to prepare the blood product. We're going to inspect it. We're going to set it up. And when doing the transfusion, we're going to monitor this patient very, very closely. What I want to point out to you all is something that's very interesting, which is if you look at box 1 here, you will see that the transfusion process itself only has 3 hours on it, right? Give the blood, hang the blood, monitor for vitals, watch for transfusion reactions, document your times, and go accordingly. But what I want you to appreciate is all of the stuff that goes on before and after to set yourself up for success, including after transfusion documentation, and then quality management, and so on and so forth. Now, let me just say a quick word about consent, because not every patient wants to receive blood products, and we have to acknowledge that, and we have to respect that, right? Patients who are verbal and conscious enough to make their own medical decisions, okay, should be asked if they are okay receiving blood. If they're unconscious, we should be proceeding under the doctrine of implied consent like we would do for anything else in an emergency situation. There is some risk, ladies and gentlemen, right? There is some risk, but in the risk, again, we're talking about in a resuscitative maneuver, in a resuscitative strategy, the benefit far outweighs the risk. And so 95% of patients will not have a transfusion reaction. 5% or less than 5% might. The infection risk is less than 0.1%. So there's a 99.9% chance of no infectious disease being transmitted. Our colleagues in the blood storage and blood bank and biomedical communities have helped ensure that we have one of the safest blood supplies, or the safest blood supply ever in human history. And so we've done a lot with screening for blood. They've done a tremendous amount, but you have to acknowledge that. Now, but the risk is never zero. And that's the important thing. When we think about consent, we also have to acknowledge that maybe this unconscious patient wouldn't want to have blood. So I would encourage you to do a very quick tactical pause to screen for medic alert signs or other signs that this patient might not want to have blood. Some Jehovah's Witness patients will have some type of like a bracelet or like a medical alert jewelry on, or like in this case, a necklace. Others will have something in their wallet. That would be a power of attorney card saying that they've accepted the risk and they don't want to have the blood. And from an EMS system perspective, just make sure that your procedures allow you to honor those things. Okay. Above all, you want to make a good faith effort, and that good faith effort should not take more than a minute, and realistically should be around 30 seconds. That while we're getting everything ready, we're just taking a quick pause so we can honor the person's wishes. And that's the most important thing, is we just want to be respectful of one another. It's a whole other story, but that's really important. If we could just respect one another. Okay. Now, blood administration. When we get to the nuts and bolts, again, no product endorsement here, but I want to show some of the commonly encountered administration systems that are out there. All right. Warmer circuits that can take the cold stored blood that's stored between 1 and 6 degrees Celsius and warm it to body temperature. These devices have a warming circuit, and you usually have that's patient facing, that's sterile. You open up out of the package, and one end hooks up to the IV tubing that the blood is coming from, the other end hooks up to the patient. and it's connected to a power source of some type. Now, as far as giving volume and giving it quickly, some systems are using pressure bags and they're having success with that. Other systems are using rapid infusers. The systems I support are using rapid infusers just because we've found that we can get the blood in faster and more predictably and reliable. Or for pediatric patients using a push-pull system, you can be very methodical about how much volume we're giving. Now, setting up for the transfusion, let's just talk about this for a quick moment here. So we have to think about having good vascular access. And what we like to say is 2 is 1 and 1 is none. So you really want to have at least 2 points of access. You want to avoid connecting your blood tubing to a J-loop or to a clave, other things that are going to downsize the diameter of that flow of blood, which could increase shear or hemolysis of the blood cells. We want to really be very mindful of having access and thinking about IOs, upper extremity versus lower extremity IOs, and monitoring for signs of transfusion reaction after the blood is given. And some of the signs that we're going to see for the purposes of us in the field for transfusion reaction are going to look like any other acute allergic reaction that we think of. Hypertension, flushing of the face. It could have hypotension as well, I should say. Wheezes, all of the classic IgE-mediated things that we think about. And so I would say this, that the data is very clear on this, that there's the likelihood of a pre-hospital transfusion reaction is no greater than the likelihood of an in-hospital reaction. So just know that from a safety perspective. Now, what about adjuncts? What about other things? Well, you've probably all heard about TXA, and at this point in time, TXA is one of those things where the data has been really, really reaffirmed that, early in hemorrhagic shock, we say less than the first 3 hours, but the sooner the better. Early in hemorrhagic shock, getting these patients TXA will help with the fibrinolysis, the breakdown of clots and the bleeding that can occur. And also calcium as an adjunct. The jury is still out on calcium, but from the purposes of the coalition's guidelines, what we have said is after the first 2 units of blood, if that person is still deranged and if that person has gotten 2 units of blood, they should get some calcium because the blood product itself has a preservative in it that can leach the calcium out of the cells. So you can make them more hypocalcemic. That's the bottom line. All right, documentation. We made it a point to be very thoughtful in the guidelines about documentation, about saying that blood is a medication, needs to be documented as a medication. You should be documenting the route and the product given. We need to document the lot number in the blood, and we need to document our assessment and our ongoing assessment of the patients. We also need to document and be mindful of other interventions that were performed and any adverse effects that we may have seen, as well as handoff care information. Training. We spent some time in the guidelines talking about what a training program should have, and there's a lot of efforts going on right now. So I don't want to speak too much about it today, but I will tell you that most, if not all, EMS clinicians, prior to implementing a blood program, will need to go through some additional training. And we spelled out what we believe as a coalition would be the essential elements of those training programs. Just as a teaser, we have some more documentation coming out in the near future about that. And so we would just add that, and we would just point that out. I would say that just one of my colleagues actually just messaged me. Yes, there's some indication that giving TXA earlier, the earlier the better is really important. But getting back to training, really important, that we have clear trainings and clear training guidelines and clear expectations. It's not just good enough to do the training. It's also important that we have ongoing training and skill sustainment as well, and competency verification, so that we all are doing what we think we're doing and doing it well. Now, what about quality and safety? Well, we talked a lot about storage and temperature and monitoring, equipment maintenance and calibration. Competencies are really important. If you're in a system where you're being tasked to giving blood and you're not giving blood on a regular basis, which many are not because of just the frequency, yet you need to have that readiness and think through it, just like you would for any other high acuity, low occurrence situation. All blood transfusion cases pre-hospitally need to be reviewed and outcomes need to be tracked. We can learn from every single one of these. We want to know and immediately be aware of adverse effects because there's a whole workflow for that. And then we have to think about monitoring for waste and think about strategies to reduce unnecessary reduction or unnecessary waste of product. The goal is to not waste a single product of blood. not always going to happen. That's the goal. As we wrap up this portion of the talk, what I would say is we also spent some time talking about implementation considerations. And we've talked about all of these, but I would frame them out for you in terms of training and education, oversight and protocols, blood supplier coordination, hospital coordination. Our hospital stakeholders have to be at the table as you're doing this because they're going to be receiving these patients. Infrastructure considerations and administrative considerations, including QA, QI, medical direction, and oversight. And for the medical director colleagues on the call, there is absolutely 100% medical director QA on these cases, or has to be. Quality control measures. We talked a lot about storage and transport already, and some of the other things that are up there, competencies and maintenance. But what I would say is the goal of these guidelines is to help make sure that you're on your way in developing your programs. So as we wrap up this section and this portion of the talk, before we go into some questions and answers, what I would say is that as these pre-hospital programs for blood administration become more and more common, it's important that we are all more similar than we are dissimilar in our strategies and our implementations. The purpose of these practice guidelines is to help do exactly that, to ensure safety, accountability, training, and policy, and appropriate clinical use. They're meant to be a resource for you if you're building a program, if you have a program. They're a living document. They're going to be updated as we have more data and evidence. These guidelines are not meant to put you at odds with your local protocols, but rather to propagate a discussion and to make sure that there's alignment where and all possible. It absolutely needs to have medical direction and oversight. And I would just, again, put another shout out to the coalition as a resource for you, no matter where you are in your journey of developing a program, because we're hard at work trying to make this as safe, effective, and scalable as possible. So with that, there are a bunch of references here, way too many for you to see. But with that, I'm going to turn it back over to, I believe, Clary at this point. And I think we have some time for some questions. Is that right, Clary?
That's right. Thank you for that talk, Dr. Levy. It's very informative. Looks like a lot of folks are taking it in. But I did have one question come in from Andrew Craig. He says his department uses packed red blood cells and liquid plasma currently. And to date, they've had great response, especially with warming. About 8% of those products that they give have been warmed. What would be the greatest reason to push for whole blood? Or would you make that push at all? And his follow-up question is also, what's the biggest downfall or challenge with whole blood versus packed red blood cells and plasma?
So, Andrew, that's a great question. What we would say is if you have access to plasma and PRBCs and that's working, I think that's great. The guidelines acknowledge that it may not be possible to get low titer positive whole blood. And if there's a single reason to switch to low titer positive whole blood, it would really come down to your unique EMS system and your duration of transport. What your system is doing is absolutely ideal and fine, and in getting the stuff that's in plasma, all the components that help us repair damaged endothelial cells into that patient is really important early in hemorrhagic shock. So I think depending upon the urbanicity of your system, Andrew, and depending upon how far you are from definitive care, there might not need to be a reason to switch to low titer positive. Now, if you're talking about multiple hours of transport time, maybe you think about a tiered system where you can get that oxygen carrying capacity on later on. But early on in early hemorrhagic shock, you're probably doing just great. And thank you for the question.
Question number 2 is going to come from Colleen Powell. She asked, what type of data are agencies collecting at the beginning of the pilot to determine success for sustainability? And before I let you answer that question, I should have mentioned this. If there are questions that come up, there's a Zoom, and then you missed the first part of our talk today, whenever we opened up, there's a feature on Zoom, the Q&A feature. It's at the bottom of your screen. If you have a question, go ahead and drop it in the chat in that Q&A feature. We'll try to get to it. If we're not able to get to it today, we'll put it in as make it a part of the archive recording of today's session. Okay, Dr. Levy, do you need me to lead that question again?
No, I'm good. I'm good with it. So I think Colleen asked, What type of data are agencies collecting at the beginning of a pilot to determine success and sustainability? It's a fantastic question. There's really two parts to that question, Colleen. The first is doing a needs assessment to figure out how much blood you're going to be utilizing, because I'm very sensitive to the fact that this stuff all costs money, and we got to be able to budget these programs as well. Historically, what most EMS systems are doing is they're looking at their high acuity trauma patients who would meet those transfusion threshold requirements as a kind of litmus test to see. Now, the question that you're asking is a little tricky to answer right now. What I would offer is it's really the data elements as opposed to the analysis of the data at this moment in time. But there are systems out there. I'm sure Holly from DC is on, to give Holly, one of our co-authors, a shout out, who collect hundreds of data points per patient. Not all of us have that luxury. Most EMS systems are collecting between 20 to 30 data points or 20 to 40 data points per patient related to blood, so we can look at outcomes tracking. Now, it is actually the focus of the SEMSTAR project, which I hope to be on a future webinar to tell you guys about, where we are working on some consensus-based outcomes through the coalition about trying to figure out what data elements should be tracked to help us get to that cause of the question. But early on, you absolutely need to track every patient who's receiving blood, how much blood they got, why they got the blood, what their initial vitals were, and then any hospital outcome data you can have. And there's more to it than that. We talk about some of this in more detail in the actual guidelines. Great question.
Okay, I've got an anonymous question now. What are one or two of the biggest takeaways you want EMS clinicians to walk away from after they have a look at the guidelines?
Okay, the first biggest takeaway is, even if you're not giving blood, we can always do something to optimize trauma care in our systems and to optimize resuscitation. So if you can't get blood, if you can't afford blood, if you don't have access to a blood supplier in your region, don't let that be the reason that your patients don't have a good outcome. Build everything else around it so that when you get to that point, you'll be able to do it. So that's number one. Number two, I think I would say that the actual administration of the blood itself is relatively easy. The actual act of giving the blood is not the hard part. It's building the system and the infrastructure around it that takes thoughtfulness, time, dedication, and a team. And this is really a team sport.
Okay, one more. How do the guidelines support EMS clinicians in the field when they're making quick decisions for trauma patients?
Well, we try really hard to keep the recommendations very concrete, as you could see in the guidelines, and to give parameters. Now, remember, the guidelines are meant to be a roadmap to help you on your local implementation, right? So that very, very insightful question really comes down to how it gets implemented locally through local protocols and procedures. But what I would say to the writer of that question is, as a medical director, I own a piece of that. As a clinician, you own a piece of it, which is that we have to have mutual and shared understanding as to what the indications are going to be, what the indications aren't going to be, and when we're going to adhere versus stray from those indications, and what our risk tolerance is. So it really comes down to a last mile, if you will, or a local implementation question.
Could you share an example of how pre-hospital blood transfusion has already made a difference in patient survival? That's also an anonymous question.
I love that question. So I can be happy to share some personal experiences. The youngest person we gave blood to in my EMS system was 19 years old and was the victim of a very severe neck laceration following a traumatic injury. That person, we got there, barely had palpable pulses and had obviously very undetectable blood pressure and altered mental status. That person got effective wound care, got hemorrhage control, got blood, got to the hospital, and was discharged a day and a half later. So that was one of the most profound ones. I most recently was on the scene of a call with a gentleman who was a motorcyclist, very significantly injured with lower extremity trauma and a pelvic fracture. And his blood pressure started after the initial adrenaline surge of the crash, his blood pressure started going down pretty quickly. He got hemorrhage control. He got a pelvic binder. We were able to get that blood into him to maintain his perfusion, to get him to the hospital, where he ended up getting well over a dozen more units of blood, as well as surgical intervention and angiography for his conditions. And then just two other quick ones, Clary. We've had had the privilege of speaking to a patient, to a survivor who was on blood thinners because of a medical condition and began experiencing severe GI bleeding, and had a pressure of 60/40 and was in and out of consciousness. And to hear in layperson's terms, this person described how they were feeling as the blood was going into their body. It was pretty humbling, and it was a reaffirmation of why we do what we do. So those are just some of many examples.
All right. It looks like we're getting close to the end of time, so I'm going to call that for questions today. Again,
Clary,
these
there's
will be
just two very
available.
quick. There's two very quick ones. If I could just jump in real fast, that I just want to try to get to, if that's okay with you. Yes, in pediatrics, you can use a smaller gauge vessel, a smaller gauge needle. Just keep in mind that you might need to, you might have more resistance pushing the blood in. That's all. And then TBI, very important question about TBI. We got to maintain perfusion for the TBI patients. Sorry, Claire, I just wanted to touch on those before we let everybody go.
It's okay. We'll get you to write those up and get. We'll put that on the website for everybody to have access to, and then you can go into greater detail if you choose to do so. Thank you for joining us again today. I appreciate you being here, and thank you to those who are watching it online. That concludes our webinar. We appreciate everybody's participation. Again, an archived version of today's webinar will be available on ems.gov pretty soon. We hope you will join us for our next webinar. Thank you and have a good day.